Throughout a career of more than 40 years, I've had the mindset of a Guilds craftsman as I've worked in the office, in the emergency room, and at the bedside in the hospital. That is the case despite my title today, which is President and CEO of Atrius Health and Harvard Vanguard Associates, Medical Associates. The truth is that my sense of identity is that of a practicing physician who, through some strange sequence of events, became a healthcare executive late in a very professionally satisfying career. I think that many physicians trained in the style of apprentices as we move through medical school and our internships and residencies also share the mindset of the guild craftsman. Based on the description in Wikipedia, which is the reference we all use these days, the guilds that arose in Europe really deserve some credit for moving civilization from the Dark Ages into the ages of enlightenment, science, and industry. These associations helped establish universities. Quite remarkably, the Barbers' Guild, established in 1308, evolved into the Royal College of Surgeons in 1800. These guild craftsmen were not only great artisans who loved their crafts and shared secrets of their trades with apprentices and one another, but they were also pillars of their communities and were fierce defenders of their independence. That description of guilds also fits the way medicine has been experienced by many of us and our patients in the not too distant past. We speak fondly of the art and the craft of the practice of medicine and love to reminisce about the days when our skills were truly appreciated. When I think of those days, I think about why I became a physician and my role model, Dr. Edward Masters. Now, I didn't have a picture of Dr. Masters, but that's pretty much what he looked like. Dr. Masters embodied all that we see in a Norman Rockwell painting of the kindly old doctor who manifests the attributes of a craftsman. During my senior season of football in high school, I was under a lot of self-imposed pressure to play well enough to attract the attention of college recruiters and maintain the sort of academic credentials that would be compatible with my dream of going to medical school. The team was not having a great season, and I became quite ill with a severe sore throat. By the time I saw my general practitioner, I was feeling a little better and had every expectation of playing on Friday night. I was floored, flabbergasted, when my doctor said that he was admitting me to the hospital because of my hypertension. I had no understanding of why it was happening and was terrified about what it meant. I was only 16. It was an awful experience except for the appearance of Dr. Masters. Dr. Masters was a grandfatherly physician who was quiet but steady and a great presence in my community. I had never been to his office, which later I discovered was in a little house on a busy street near my home. I knew him because he taught Sunday school in my church. Somehow I knew that he had been trained at Vanderbilt and was an esteemed member of our community. He came into my room and sat down at my bedside and explained why my doctor had admitted me and proceeded to reassure me that he understood how important it was for me to get back to my team and my plans. It was too late for the game that week, but he assured me that I would play the next week, no matter what the test showed. I think he knew that my primary physician had probably overreacted. That'd be my guess from this perspective, looking backwards. Anyway, over the remainder of that year, I would occasionally see him in the office. I waited in the parlor, was examined in what had been a bedroom, had my blood drawn and an EKG done in the kitchen, and saw his secretary in the dining room where she managed the practice and gave me my next appointment. 13 years after Dr. Masters had sat at my bedside, I began to practice medicine in the new environment that Dr. Ebert had created at Harvard Community Health Plan. My family kept asking me when I was going to start my own practice. But I realized that time in advance had forever made the sort of solo practice that Dr. Masters had had a fading memory. I think we reminisce about grand old clinicians like Dr. Masters because they embodied the skills that we, as physicians, value most. Solving problems for patients with our clinical thinking, our critical thinking, powerful reciprocal relationships with patients, and the opportunity to use the clinical skills that we work so hard to obtain to the benefit of those who trust us. When our marketing department surveys patients about what quality means to them, the patients do not answer with HEDIS measures. Instead, they are looking for a doctor who listens and communicates. Dr. Masters lived in a world of guild medicine, and he was a master of listening and communicating. In memory today, he provides me of a picture of what so many patients are still looking to find in combination with the high tech and science of our current medical industrial environment. Medicine is rapidly morphing from being a guild-like activity to an activity embedded in an enterprise. The enterprise is necessary to handle the complexity and the capital needs of today's medicine. Yet many of us have our hearts trapped in the model of the craftsman. We daily express our desire to be free and independent of the onerous regulations and administrators who lack personal understanding of the difficulty of working under the scrutiny of the rules of politicians and the threat of the plaintiff's bar. Our independence is threatened on the one side by hospitals who want to control us to serve their objectives, and on the other side by investors and agents of other business interests who see healthcare as a great opportunity if they could only control the flow of patients by controlling the doctors. In other words, one could say that we are now a guild under siege. I posit that we can be true to our best intentions and exercise the best of our guild values while our craft becomes a part of an enterprise that is beginning to be known as an accountable care organization. I want to share with you my observations and reflections about what strategies have worked for Atrius Health in a time of change and what we have learned from what did not work so well for us. Let me start by introducing you to Atrius Health. We are an organization that is continuing to evolve towards a more integrated system of care. We are comprised of 6 multi-specialty ambulatory group practices that are working together towards the goal of the triple aim. To these goals, we've added a +1 goal, that is improving the experience of practice for our physicians and our staff. The Atrius Health groups are often held up as an example of an accountable care organization because we began the move from guild to enterprise so much earlier than many of the physician practices in the Commonwealth. The largest medical group in Atrius Health is Harvard Vanguard Medical Associates, which is, as I had mentioned before, the legacy practice of the staff model HMO of Harvard Community Health Plan. Dr. Robert Ebert, then the Dean of Harvard Medical School, was our founder. After struggling for several years to get funding and working against the resistance of many, and with the help of a few key people like George Thorne and Howard Hyatt, who understood his dream, Dr. Ebert launched the Harvard Community Health Plan in 1969 with 88 patients. That was a time of transition, much like this time. Dr. Ebert and other thought leaders were as concerned about the future of medicine in those early days after the passage of Medicare and Medicaid as we are now, working against the uncertainties in the aftermath of Massachusetts chapters 58, 305, 288, and 224 and the Affordable Care Act. Dr. Ebert was an early proponent of the advantage of population-based health care and believed in the value of preventative care and health maintenance. He was quite familiar with Kaiser and was interested in how their concept might be expanded with his relationship with Harvard Medical School to become a teaching practice. He wrote and spoke extensively about how his era was not training young physicians to practice in the ambulatory environment where he believed the future would be focused if we were to ever improve the health of the public. Dr. Ebert had triple aim thinking 40 years before it was described as a concept by Tom Nolan and others in 2007 at the IHI. He dreamed of a prepaid ambulatory medical multi-specialty group practice focused in a community that could meet many of the needs of the patient under one roof. The practice in his vision would be somewhat like a hospital, but differ from the hospital's outpatient department or the average community physician's office. In his new environment, medical students, interns, and residents could be taught the art and science of medicine in the patient's world, focusing as much on the patient as on the patient's disease. He was constantly trying to substitute prevention for treatment of chronically neglected problems. In his thinking about this new type of practice, Dr. Ebert was not planning to abandon the guild values of his profession. Rather, he hoped that a new environment of patient-centered prevention would eventually replace much of the environment of the hospital. He believed that much of what he saw in the hospital was dangerous and misdirected, and in his day, it was all arising from fee-for-service finance. He talked from the perspective of a scientist and hospital specialist who was disappointed that in the world in which he lived and worked, there was misalignment with the results he believed were possible and needed. Dr. Ebert recognized much earlier than most of his contemporaries that despite great science and exploding technology, something was missing from the application of those technologies to the patient. He understood the tension between volume and value long before many of our current practitioners were born. Because Dr. Ebert understood the undermining power of waste, he wanted to start a practice that could only be financed by finding cost efficiencies while still delivering more and better care for less money. ACHP practiced team-based care with nurse practitioners and an automated medical record from the first day it opened its doors. I began my medical studies at Dr. Ebert's medical school in September 1967. The following month, Dr. Ebert gave a speech about the future of healthcare at neighboring Simmons College. In that speech, he said quite profoundly, the existing deficiencies in healthcare cannot be corrected simply by supplying more personnel, more facilities, and more money. These problems can only be solved by organizing the personnel, facilities, and financing into a conceptual framework and operating system that will provide optimally for the health needs of the population. Harvard Vanguard is not the only Atrius practice with a history that is rooted in the traditions and values of patient-centered practice with elements of a guild-like past. The second largest Atrius affiliate is Reliant Medical Group, which is the legacy practice of Fallon Clinic, with an even longer history of practice innovation with guild-like roots than that of Harvard Vanguard. Dr. John Fallon brought a team of physicians from the Mayo Clinic in 1929 to Worcester to create the first group practice in central Massachusetts. The other four groups of Atrius Health all have deep roots in the environment of private practice, combined with strong experience in managed care. South Shore Medical Center opened 50 years ago, Southborough Medical Group 60 years ago, and Dedham Medical Associates 75 years ago. Our smallest group is Granite Medical Group in Quincy. Its history may be more typical of the path of many physicians in our community now than the one I described for myself. Its founder and president, Dr. Guy Spinelli, and this is not his driver's license picture, but I think it's the one that's on his badge, opened his practice fresh out of training in 1982 in a small office in a house with his mother working as his only staff and as his secretary and support. Later, he acquired a partner, and then he and his partner created a small primary care group, which then later affiliated with a group of medical specialists to form Granite Medical Group, which then joined Atrius Health. It is astounding that in one physician's practice lifetime, Dr. Spinelli completed the transition from a cottage environment and with true guild-like sensibilities to an environment that is perhaps or soon will be called Big Med. And he still has preserved the same values. In preparation for this speech to you today, I asked Guy what was on his mind with each step in his movement from solo practice to the enterprise level of practice. His answer was simple. It was that with each move, he was driven by what he thought was best for his patients and his community. He was always asking himself, how could he offer more to the patients who depended upon his judgment? Today, there are more than 1,000 physicians employed by Atrius Health affiliates to work with more than 1,500 other licensed healthcare professionals and 5,000 other professionals in an enterprise that provides about 3.5 million ambulatory visits every year to more than 1 million Massachusetts citizens. About half of our physicians work in primary care. We work in about 18 preferred hospitals. Atrius Health groups offer patients 50 sites across central and eastern Massachusetts where they can get care that is designed to make it easier for them to be healthy close to home. We have long been known for our quality. Our annual revenues are in excess of $2 billion a year. The physicians and other professionals, Atrius Health groups, use the most sophisticated IT infrastructure and big data resources that are available. They are supported by clinical pharmacy, care managers, overnight telecommunications staffed with advanced practice clinicians, and weekend urgent care. We have partnered closely with VNA Care Network and Hospice to enable more than 500 nurses to bring their in-home care skills together with the Atrius Health groups to create the possibility of even more innovations as we seek to make it easier for our patients to enjoy good health. In a recent article in the New Yorker called Big Med, Atul Gawande compared the evolution of restaurants from small local establishments to large chains of very efficient restaurants like the Cheesecake Factory. He thought that evolution was something that we might mimic in healthcare. It was that comparison that gave many of you indigestion, but there was much to chew on in his metaphor. He wrote at length about the pride that each chef took in what he or she was able to create in a system that had standard work and a common menu. Gawande's definition of Big Med hit close to home because two of our local iterations of Big Med, Steward Healthcare and Partners Healthcare, were actually showcased in his article. Dr. Gawande said, "Today, some 90 super regional healthcare systems have formed across the country. These are large, growing chains of clinics, hospitals, and home care agencies. Most are not-for-profit. Financial analysts expect the successful ones to drive independent medical centers out of existence in much of the country, either by buying them up or drawing away their patients with better quality and cost controls. Some small clinics and hospitals will undoubtedly remain successful, perhaps catering to the luxury end of healthcare, the way gourmet restaurants do for food. But analysts expect that most of us will gravitate to the big systems, just as we have moved away from small pharmacies to CVS and Walmart." As I thought about the article, I asked myself, would I want to practice in a cheesecake environment, even if it was efficient and effective? I reflected on the efforts that our management team has invested over the last 5 years as it has tried to lead our practices towards the triple aim by throwing an avalanche of new programs and initiatives at our clinicians. Over 5 years ago, Atrius Health anticipated the fact that the year-over-year increases in revenue that were necessary to support our practice would end someday. Our revenues of almost $2 billion a year, a drop of 5% in 1 year would produce a sudden $100 million deficit. We could imagine such a fall if revenue increase dropped from the 8% that it was then to 3%. Many of our groups had survived a 30% loss of revenue in the 1999-2001 era when Harvard Pilgrim Healthcare went into receivership. It was hard to maintain quality in those days, in the midst of that crisis. We literally burned the furniture to get through that winter of financial discontent, and we did not want to do it again. Our 2008 strategic plan included an effort to support the movement to global payment, since we felt it was easier in that environment to create programs that lowered cost. Our data showed that there were some potential hospital partners who would give our patients equal quality for a lower cost. Conversations with those hospitals convinced us that they saw the same compelling reasons for change that we saw, and that encouraged us to move business to them since we buy significant specialty and hospital support. We decided to invest resources in a leadership academy and improved data systems. We tried to broker conversations with others in the market about forming relationships that would be cooperative and better support the community. We supported team-based care, and I began to speak about the need to move from I am accountable to we are accountable. All of our practices became level 3 NCQA certified patient medical homes, but we still continued to refine the model. We recognized that some of our patients thought our technical quality was better than our service excellence. So we talked with institutions whose patients scored their service as superior to ours, and then hired the same consultants they used to help us improve our service. Our biggest investment decision was to embrace the huge task of giving a workforce of over 7,000 people skills in lean methodology for eliminating waste in our processes and increasing respect for the people who actually do the work. We had been impressed that lean had enabled Virginia Mason Medical Center and Group Health in Seattle, Theta Care in Appleton, Wisconsin, and Denver Health to become better at getting better. The process was described as a long journey that required great change. We decided to try. We focused on respect and recognizing and eliminating waste. There are 8 types of waste that lean identifies, but I think the focus for me most recently has been on practice variation and over-processing. But once you begin to think about waste, it's amazing. You see it everywhere. We tried to define value in the context of our patients. We created standard work, which is a term that does not cause many physicians to have warm and fuzzy feelings, and instituted management for daily improvement, an equally technical sounding term. The goal was to develop processes where every step added value and where all of the mundane and routine things are handled through consistent processes so that extra time can be dedicated to physicians thinking about the needs of their patients, both in the office and in a proactive way. Finally, be honest, we accepted help from our friends. Blue Cross supported innovation with a grant that was coupled with executive education and then produced a new payment mechanism called the Alternative Quality Contract that gave us a reason for action and some of the resources to pay for the change. We challenged ourselves to learn about shared savings programs and invested in care models to be successful in the ACO environment, becoming one of the 32 Medicare pioneer ACOs in the nation last year. Some of this investment has worked out very well, and we have put in place many of the assets that will be necessary to succeed in a world of mostly global payment. I will borrow from Ronald Heifetz and call this part of our strategy the technical change. With technical change, the problems are well defined, the solution is known or can be easily found, and the work that needs to be done for implementation is clear. Much of the technical change that we challenged ourselves to initiate, because it would be of benefit in a new world, have actually been accomplished. For example, as the results of the work that we did, we moved tertiary care to the Beth Israel Deaconess Medical Center and moved much more care to convenient hospitals in the community. We have significantly improved our AQC quality scores each year. The lessons we learned as we improved the quality scores in the AQC have been valuable to us now as we enter the Pioneer ACO, where access to shared savings are available only if quality is acceptable and the downside risk is mitigated by improving quality. We are beginning to see improvement in our patient experience scores. The most significant return has been on our investment in lean. We have several thousand employees across all groups now who have robust lean vocabularies. They're coming together daily in their units to plan work for the day, share what is working, discuss problems, and come up with solutions to improve the flow of their shared work. This is an A3, which is a tool that we frequently use in lean to design the solution to problems. In essence, it's a scientific method for groups. And here are the groups. You can see sites like this all over Atrius Health almost every day. On Fridays, I went to one this morning. There's a report out of the work that was done, and the imagination that I have as I stand there is with a few thousand more of these, we will actually make a difference. But these folks are coming together daily and enjoying it. We have used Lean to solve problems that arise between different departments, which is difficult. Design new facilities. Our Concord Hillside facility is a P2 project which will be created, which is under construction now and was created with the help of patients in a Lean process. We've also been able to use Lean tools to create common specialty services between Atrius Health partners in a process that's just begun, and also between Atrius Health and its hospital partners. Some of our greatest gains have been improvements through Lean at the front desk, in the pharmacy, and in the laboratory. Tracking the ROI on Lean is very difficult because so much of it becomes just the way that we think and work. But there is no doubt that the investment has been returned by several multiples. Perhaps the greatest benefit for Lean has been the engagement of our workforce, these folks, and management in a new type of empowered partnership. Our data warehouse capabilities have been an enormous asset as we work with hospital partners, payers, and plan programs and services with them. We're able to track utilization to individual clinicians and are developing the skills that will enable us to improve practice variation and follow utilization of lab and consultative services. We can now do meaningful analysis of our high-risk patients. We have scorecards to measure our relationships with health plans and hospitals so that we can help them improve with us. We can analyze variation in practice patterns, share best practices, and see both improvement and decreases in utilization. Here's an example. I don't want you to look too hard at the slide. Some of the numbers are not as good as I would like them to be, but they're all moving. With each of our sites, we grade them as red, yellow, or green for performance. If you look at the column for hypertension, right here where the arrow is, you can see how the sites are faring. This allows us to find those that are doing the best job and then determine what it is that they are doing. And by sharing this information, we can spread what they've learned to other sites and also reduce the variation in our practice. In another example, we find those who are ordering tests that are not clinically relevant and give them that feedback. That's actually a slide showing how we've improved, and each line represents a different unit. Here, the little blue bar shows you where we were in July, December 2001, and this is for something very simple, just ordering CBCs before a visit, whether they were needed or not. And below, you can see where they had gotten to by June of 2012. The differential between those lines is many millions of dollars of savings on the basis of something that was providing no value either to the patient or to the clinician. The American Board of Internal Medicine has adopted this same technical change process. They've asked each of us to follow the advice of medical societies to select 5 practices that could be eliminated. Together, there are approximately 45. And I'm sure many of you know about the Choosing Wisely program. The thought is that knowledge is power, and just knowing what is wrong can help change practice. Yet we know how often that is not the case in medicine. Even when we have good data, our guild mentality produces huge and often unjustifiable variation in practice. We experienced this when we developed standard work for our patients with diabetes. There was a need for a common definition. We had to pick from A1Cs or fasting glucose. We needed agreement about the order in which we would try different medications in the absence of clinical signs to try something else. We had to get agreement from almost 200 internists at Harvard Vanguard about the frequency of follow-up visits and the screening and health education needs of these patients. We've made great progress, but we are not where our patients need us to be. We are measured on our ability to improve these patients' health outcomes, yet we know that our ability to ensure that patients receive all recommended screening is far less than 100%. And although outcomes have improved, there's more work and more learning that must occur before the results that we want match what we have accomplished. As we went through all of these technical changes, we began to realize that we were not moving as efficiently as necessary toward our goal. We looked at the experience of other organizations like Virginia Mason and ThedaCare and realized that they had taken the time to establish a social compact with their physicians to resolve some of the tensions of adaptive change. We spent a year at Harvard Vanguard creating such a social compact with our physicians, which we envision as a continuing process that will spread to the relationships that we have with our governing bodies and also with the other professional types within the organization. It is difficult for me to imagine where we might be if we had not looked into the future and prepared as we have. I know that we would be in a very different place than we are now, but are we where we want to be? The answer is clearly no. Despite all of the investments and all of the information, we have not been able to progress as far or as fast as we had hoped, and perhaps partial success has been the impediment to progress. I'm sure that some of our physicians, it is really hard to work harder to avoid a crisis when you're doing well in the present. I'm sure that some of our physicians and staff have thought that the predictability of the difficult times that I've talked about in the past would never happen, but our projections suggest that expenses will actually come close to revenue sometime in 2013 and 14 if we don't accelerate our rate of improvement. To continue without even more improvement will be a recipe for disaster. With the early start, we had hoped to push down our TME faster than reimbursement fell, but we will have to pick up the pace now in our progress if we are going to stay ahead of the falling reimbursements. Those falling reimbursements will introduce the necessity for severe cuts, which I know would lead to a predictable loss of the quality that we fought so hard to obtain. So what could be better? I do not sense that the work lives and the satisfactions of our physicians have improved as much as we had hoped. That had been our goal, but that is not what we've achieved. Their energy is a real rate-limiting factor in our progress. They are still spending an enormous amount of time doing tasks that are not top-of-the-license tasks. The process of standard work from doctors, besides being repugnant as a concept for some, is just really, really hard to create. As a result, many of our physicians do not share the enthusiasm for lean that I have and that many of our other employees have. I sense there are many who continue to struggle mightily with the increasing work-life imbalance in their own lives and are continuing to feel the pain of adaptive change. Lean thinking is built on the concept as a scientific, on the same concepts as scientific method, and its success is predicted on demonstrating improvement with appropriate measurement. Many times the postulated solutions that arise in the lean process fail to generate the results that we were looking for. When that happens, we rethink and then develop countermeasures. The process actually has a name, it's called an A4. When that happens, we almost always find something that we've missed and another way to improve what we're trying to do. At this juncture, we only have theories about how to get better in the area of improving the physician's life, but we believe that the solution most likely lies in improved performance of management and developing even better standard work for everyone in the entire organization, from management through clinicians down to the rest of the staff. Everyone on the team needs to everyone on the team needs to better understand and better fulfill their particular role in the care model. In lean management, better performance and accountability is associated with coaching, mentoring, and teaching. Recently, we've added more site medical-based leadership to support these activities. During this last year, we also freed up more time for our internists to do practice management and to participate in management for daily improvement activities without decrementing their income. I'm convinced that improving the experience of practice remains the greatest challenge that faces us all. I know that new physicians who come to our practice basically think that they've come to a Disney World of supports. And I know from my own traveling around the country that there are very few practices that are supported the way our practices are. Nevertheless, those people who are working in our practice still feel as if the burden is quite heavy. There are also new problems on the horizon. Because of the demographics of practice, with many of our PCPs retiring at the same time that we have a gray tsunami of patients who were once baby boomers, our greatest challenge as a profession in the future probably lies in the issues of workforce. I fear that even before we evolve the ability to manage our current loss of resources, we will have a much greater problem. This is a chart that actually shows that by 2025, we will be down 130,000 physicians in the country, of whom almost 66,000 will be primary care physicians. SG2, the data firm from Chicago, predicts that by 2020, there will be one primary care physician for every 10,000 American adults. That thought alone gives you reason to pause and to realize that what we're doing now won't work then. As a physician, I too have known better days. The last decade has been increasingly difficult for all of us. The statistics that suggest that any increase in physician income that we've experienced has come as the result of working even harder. And it's now harder to work harder than we're working. And the downside of that has been that we've been spending much less time with patients and using much less of our time for critical thinking. There's actually some reality to this cartoon. I'm sorry. I thought I could have saved him, but there was just too much paperwork. I fear that some of the things that we have not successfully transferred to Big Med, as we've moved so much of what we do into that environment, is the time that we need with patients and the time that we need to ponder their problems. I think it is ironic that we are now attempting to improve utilization of scarce resources through a program called Choosing Wisely, when we hardly have time to think what might be wisdom. The wisdom to choose is actually a time-consuming thing. I heartily and enthusiastically support Choosing Wisely, but I think we actually have to create the time to do it. So what do? Instead of choosing wisely, we substitute a few keystrokes on the computer, ordering a test, hoping that the answer to the critical problem will arise not from our critical thinking, but appear magically in the inbox. Because we do not have time to think, to consult the literature, even though the literature is now online. Recently, I had a wonderful opportunity to spend an afternoon with Clay Christensen at Harvard Business School. He invited me, as well as the other leaders of the Massachusetts Pioneer ACOs, to come and talk with him and Dean Flyer from the medical school, Harvard Medical School, about the challenges of ACOs. I think he conceptualized it as a disruptive innovation. 4 of us did make it, and then he asked the question, what does your customer hire you to do? Being somewhat literal in my thinking, I said, well, it depends on the particular patient. As the words came out of my mouth, I realized that I had missed the point. It is true that pregnant mothers hire you to deliver their babies, and people with broken bones hire you to set their broken bones, and elderly people with swollen ankles who are short of breath do want those problems resolved and will hire you to hand them a prescription for furosemide. But generally, the job that patients hire us to do is to care about them and to listen to their concerns and to think about them long enough to help them solve their problems efficiently and effectively. This kind of care is very difficult to deliver on a 15-minute appointment. A great use of all of our big med tools would be to restore to us what few of us can now barely remember, the time to listen and think. I do not think that most physicians have given up caring, but I do think that it's been a very long time since many of us have had the time to do what we learned to do in medical school. The shame of it all is that if you have graduated from medical school in the last 15 years, you may never have even had the opportunity to know what I'm talking about. I can testify from my own experience that as physicians are pushed into big med enterprises, there will be substantial pain associated with the loss of autonomy. They also have a sense of entitlement and protection that we've crafted for ourselves over the years with our guild environment. Dr. Heifetz again calls this reality the pain of adaptive change. He says that adaptive change is characterized by the fact that the challenge is complex. To solve the problems that the challenge presents requires transforming long-standing habits and deeply held assumptions and values. It involves feelings of loss, sacrifice, sometimes a feeling of betrayal to values. I think I've just described that. And sometimes the solutions require learning and totally new ways of thinking and new relationships. It's a pretty prescient list. He made it some time ago. I've come to believe that the real antidote to the pain of adaptive change lies in preserving the patient-centered values of our old guild-like days. The antidote to the pain lies in the intense devotion to the patient, the opportunity to apply our critical thinking and the sense of professional unity in the faces of challenges, and we have always done that as a profession. The new challenge is to see the extension of our old proven values in these new contemporary forms of practice, and to carve out the opportunity and time by efficiently improving our models of care, to have the time to spend with patients and to think critically about their problems. The transition can be difficult to do when you're talking about standard work and the physicians are fatigued and realizing the sense of loss and are thinking only that they will lose more of their ability to take care of individual patients and more of their ability to think unless things improve. We must use all that was great about working in a guild combined with today's science and organizational structures of Big Med to ensure a better future for all of our patients. In retrospect, back in 2008, Atrius Health Management approached the changes necessary for the future as if they were all technical change. That was an error. We thought solutions would emerge from reasoning and logic, and it would be a matter of just doing it. As much as I valued our guild heritage at that time, I did not realize that the future did not require leaving the guild behind. Rather, it required moving the guild thinking and the associated values of our relationships with our patients and our ability to think critically and to apply our technical skill into a new environment. When Elliot Fisher from Dartmouth first coined the phrase accountable care organization, he had looked at the organizations that were producing the best quality at the lowest cost and saw that they were creating opportunities for physicians to work together in teams with others, managing the care of the patient across all settings and bearing the responsibility or accountability for both quality and finance of their patient's care. That was just technical change for me. That part makes sense. Doing this for Medicare fee-for-service or PPO patients, however, is another story and something very new. Accountability for patients' outcomes and expenses without the ability to manage their referrals tightly with a contract made no sense at all to me. That would be impossible, I thought. But then Elliot added a phrase that resonated with me and was a challenge to our ability to satisfy patients. He said, "The best fence is a green pasture." Elliot's statement eased the burden for me personally of adaptive change. It made sense. The first goal of the enterprise, the ACO or Big Med, should be to provide such complete and accessible care that there would be no desire to leave it. The work is still hard, but the path to success is clear. The path is an old familiar path of guild-like patience and practice. Dr. Spinelli knew that path. He said to me, "Put the patient first. Solve the patient's problems and your business problems will improve." Most Massachusetts physicians will practice in a big med environment in the near future. The era of solo practice and even the era of small group practice is rapidly disappearing. Ahead is a continuing struggle against the total cost of care, with most of us employed and independent only at a personal level of professional attitude. Some of us will work somewhere in the network of a large tertiary system that is connected to communities through hospitals it controls and through their affiliated practices. Some of us will work in an investor-backed system of care that owns community hospitals and affiliated practices and seeks to keep care very local and engineered for efficiency. Others of us will work in groups like Atrius Health, led by physicians. But all of us can come together in our connection with the Massachusetts Medical Society. The Society is an effective advocate for patients and physicians. With one voice, we can advocate together for our values, our patients, and our communities. Our enterprises, no matter how large, do all that they do with acts of care that are connected to us. We control the future. We as physicians can assume a mantle of professional leadership for adaptive change and put the interests of our patients first. I do not think we have ever faced a greater problem with more potential impact on our patients or on our collective economy than we now face. Our goals and our new tools have not yet produced the results that we need to ensure that we will be able to have the right amount of time with patients and the right amount of time for critical thinking. Yet, that is undoubtedly the only way that we can simultaneously improve quality, reduce costs, and improve the health of the population. And we must achieve these results by changing the way we utilize our physicians, since we cannot just throw more resources at this problem, which is what Dr. Ebert said 40 years ago. When we solve this problem, we will have truly transformed the delivery of care from a guild to an enterprise, but it will still feel like the best of what a guild could do as we handle the complexity of our current environment. Atrius Health has not solved the problems of improving the experience of practice in the big medical environment or in the ACO environment, although we continue to work towards that goal. We must keep trying if we ever hope to create the environment of care that our patients want, where we do the job they want and stay with us because we provide the care that they value and not just because they have a low-cost contract for health care that forces them to stay in network. As I travel around the country visiting other practices and discussing the issues that face us all with other physician leaders, I see reason to be hopeful, but I still do not see a definitive solution. I miss the guild-like qualities of practice that we enjoyed in the past, and I hope that eventually we will find a way to find them again in the new big med environment. If we can do this, if we don't succumb to the misery and disillusionment of adaptive change while we are involved in the process, we will be protecting our patients. I have confidence that we will choose the needs of our patients and our communities over our own and find a way to solve these problems. History suggests that solving problems for our patients is what physicians always do. I believe that we are all committed to a better future, and together can discern how to make it real. I've always liked this statement from Charles Handy. The future we predict today is not inevitable. We can influence it if we know what we want it to be. We can and should be in charge of our own destinies in a time of change. Thank you very much.